All right, good morning, everybody. I'm Gail Ryder, and I'm the Vice President for Behavioral Health at Baycare Health System in the Tampa Bay, Clearwater area of Florida. And I want to start by giving a shout out and a thank you for Discovery Behavioral Health for sponsoring this morning's opening session. So let's begin. I'm pleased to begin today's opening session and introduce Dr. Molly Coy, who serves as the physician leader in Medicaid transformation at Avia, a leading network for health provider systems seeking to innovate and transform through deploying digital solutions. I think two things that you heard me say, Medicaid transformation and digital solutions, are very dear to the behavioral health heart. So we're really happy to have Molly here today. Previously, Dr. Coy served as the CEO of Health Tech and earlier as the Chief Innovation Officer of UCLA Health. Baycare knows of Avia and knows of Molly's work, and we promise that her presentation will be both interesting and applicable to all of us. So please help me welcome Dr. Molly Coy. Molly?
Good morning, everyone. Come on, once more. Good morning, everybody. Thank you very much. We all have to wake up together, especially those of us who came from the West Coast. But thank you very much. I want to thank Mark Koval, and I especially want to thank Bay State for helping set this up, because this has been a passion of mine for a long time, Medicaid and underserved populations, and how technology, contrary to what many people think, actually can be very helpful in meeting the needs of this population. And so what I'm going to talk to you about today is how about 44 different health systems in the United States as delivery systems in medical care have joined together to try to do something about Medicaid and transform care for underserved populations. And along the way, one of their top priorities, of course, is behavioral health and substance abuse. And so I'm very happy because my mom was a mental health social worker. And when I was commissioner of health in the state of New Jersey, we had responsibility for mental health. As you know, half of all states, it's actually in the public health department, half it's carved out. Everybody has a different opinion about which way it works well, but it gave me my first opportunity to really understand the challenges and the way different delivery systems, provider systems were meeting those challenges in behavioral health and substance abuse. So with that, I'm going to see, Mark, if I can pull this back, because I can't see this. I must be too short. I can't see the screen over here. Yeah, I think I just got it. Yeah, it wasn't a technical solution, but I got it. Okay, so, yes. So I always start off with disclosures and disclaimers. You know I'm a physician, and all the sensitivity about physicians who are paid by drug companies and that kind of thing. So I always want to put everything out there at the beginning. So as we first heard, I'm the executive in residence and executive sponsor and physician lead for the Medicaid Transformation Project at Avia. And Avia is now 46 health systems, and we were formed about 5 years ago and grew very rapidly. And the theory behind this is that it is simply too difficult for any individual provider system to actually sort through all of the digital technologies. And so these organizations join Avia and pool their membership fees to support work on their behalf. So they say to us, for example, we want to understand virtual triage. And so we'll do research for 2 or 4 months on that, narrow it down working with our members, and come up with a mutual agreement with our members about the recommended 1, 2, 3 best solutions in that area, and then help them adopt it. We're not a consulting company. We're a pooled group of membership fees to research the area. So we don't do the individual work for an individual system. We're trying to come up with the solutions that will work for most of our members. And not every member is interested in every single topic, but Medicaid is the highest level of participation that we've ever had because Medicaid is such a tremendous challenge right now. I also, for the last 15 years, have been on the board of Aetna, which many of you know is a health insurer. And I also work with a number of small companies advising them because, as I said, I'm very passionate about how do you grow technologies that it can actually be helpful. And so in this presentation, I'll describe two of them, along with many other companies that I don't have a relationship with. So those are listed here. But I will always tell you if I have a financial relationship with any solution that I'm describing. Okay, so that's the way, sort of as a physician, you try to stay clean about all of this. And so I want to point out that the examples that I'm giving here are very real. They're on the market today. They're being used and used successfully. We are in the midst of a very deep dive on behavioral health for our members. And so I will talk to you about a couple of companies, eMocha and Chess, as examples of digital technologies that are newly emerging with very great promise in the area of behavioral health. But I'm also going to talk about the medical side because given the amount of money and the amount of investment going into it, some of those are showing us the next wave of what digital can do. That's building on top of, however, the history of mental health and behavioral health in this country, which was digital before most of the rest of medical side was. So I want to really recognize the role of teletherapy, telepsychiatry, of the Veterans Administration, of many other leader organizations in using the first generation of telemedicine for helping patients. That's tremendously important, whether it's from the provider to a provider, like a consultant in a hub to a remote provider setting, or from a provider to the patient during a visit to a clinic or a treatment site. That is something that was established very strongly in mental health and behavioral health long before it was used as widely in medical side. But now we're seeing some of the newer forms of digital advancing on the medical side very rapidly. And so I'm going to be showing you some of those as well. But the inclusion of all of these is intended to be illustrative. There are multiple entrants in each of these fields. In some cases, there might only be one or two. In other cases, there might be 5, 10, 15 competitive entrants. And one of the things that Avia does is work with our members to find out what's right for them. And so we're putting in front of you ones that have survived some of that screening, but it doesn't mean that they are the only one out there that's good, or that given your needs and your specific population, if you decided to use one of these in some way, you wouldn't want to review it with us in addition. Okay? So the Medicaid Transformation Project has the goal of dramatically improving health care for Medicaid and underserved populations by leveraging scalable, replicable innovations. And what we mean by that is that there are many things we know we need to do. For example, we've had 30 years of research to show that community health workers are very, very helpful. But less than 5% of patients in the United States with chronic diseases of any type are supported by a community health worker. It's just plain too hard for a lot of health systems to get them going and off the ground. What we're looking for is the digital solutions that make it easier and less expensive to provide the support for the patients that we otherwise would have to do with in-person visits. One of the key recognitions we have is that for about no matter what technology it is, 5 to 15% of the population, the digital solution may not be appropriate. So right away in your mind, don't assume that just because it doesn't work for everybody of a certain patient population, that we would reject it. Because if you can take care of even 80% of a population with some digital means, it frees up resources to devote to the people who are the most troubled, that you want to have the focus of your professional time and your resources on. Another interesting fact, what percentage of the Medicaid population do you think have smartphones today? How many of you would guess 25%? 40%? 50%? 60%? The percentage of Medicaid patients who have smartphones is exactly equal to the commercial population, 86%. Now again, in your mind you're thinking, but my patients don't. You know, if you're seeing the ones who wind up hospitalized with very severe conditions, even there, some of them do, and it's amazing. But remember what I said about the 80-20 rule, that a very high proportion of people who show up as your patients have smartphones. The way we're doing our work in the second point here is collaboration. As I said, pooling our efforts and our research. The way each individual provider will actually adopt something and use it may be very different. And frankly, the competitive advantage is less in having the knowledge than being able to do something about it. And that's why we work with our members very closely on trying to help them actually, once they've made a decision, adopt and scale something so that it's successful for them. And our impact, we hope, will be to improve the health of Medicaid and underserved populations in measurable high-impact ways. And we've been doing that in some very specific ways so far. And so now as we're heading into the behavioral health and substance abuse arena, we have every reason, based on the cases where we've already seen these technologies being used in behavioral health and substance abuse, to think that our members will have success in this too. But they need help from you, people like Gail, inside the members, or as others in the community of providers with expertise, so that they can actually be effective. These are just a quick snapshot of the health systems participating in the Medicaid Transformation Project. This is national, spread across the whole country. And these are the 4 areas that were prioritized by medical provider systems looking at Medicaid. So you can see 2 of the 4 priority areas are behavioral health. I won't read all the contents because you know what this, and undercutting all of them are the social determinants of health and the need for patient engagement and health literacy. What we heard from our provider systems can be summed on the right-hand side by 3 things. Access. We've got to broaden access points, streamline integration so that the systems are not as siloed as they are today, and extend and educate workforce. Above all, leverage the scarce workforce that we have now, because that is the greatest barrier. And so in each case, what we do is look at the care model categories. So in screening and triage, we know that we need universal screening and triage to the appropriate site of care. We need collaborative care management in order to direct people to the right resources, and have trauma-informed care as a part of that to inform both pediatric and adult assessments. When we come to behavioral health integration, co-location, coordination of care management, and health homes is one of the models for that. are very important. Under crisis intervention, there are a variety of models: crisis stabilization centers, the 23-hour model. So we do a complete category of all the major care models. Many of those care models have been demonstrated to be very effective, but are not widely used in the United States yet. Part of that is for reimbursement barriers, regulatory barriers. In many cases, the lack of availability of enough personnel, the cost of mounting feet on the ground services. So then, once we understand the care models and what behavioral health and mental health providers want to do and are trying to accomplish, then you ask the question, what are the digital opportunities? So we don't start with digital. If you start with digital, it's like starting with a loaded gun and sort of saying, well, okay, or a hammer looking for a nail, and everything looks like a nail. Digital isn't right for everything. Digital doesn't solve everything. We're asking the question, where can digital actually add something? And you can see here, that's just a sub-sample of lots and lots of companies out there. In general, when we talk about digital helping in frontline population health, what is it that digital can do at scale? It can do analytics. It can identify the clinical risk, the social determinants of health. It can assign interventions. It could say for this subpopulation, the most likely positive result will be with this intervention. And it can test interventions when you have an idea for something that's a different kind of intervention or a modification. It can test that. It can identify rising risk, that's people who don't yet have a diagnosis but are at risk of it, and near-term high costs, meaning who are the people in the next 12 months that are really going to get in trouble and cost a lot of money. Triage, it can assign the appropriate site of care so patients don't come to the emergency room or the community clinic when they need to go to the emergency room. They don't go to the wrong place. In order to do that, the triage systems are applying diagnostic capabilities that with artificial intelligence get so good that they're now competitively as good as the medical providers in clinical care in many cases. Diagnosis and treatment selection. They can, given the triage assessment, drive the diagnoses on the clinical side for primary care. So for example, in a behavioral health setting, you could use one of these systems where you don't have the ability to bring a medical provider on site. Community specialty care and treatment plans. Increasingly, when these systems make a diagnosis, that includes the linked understanding from these systems about what the most appropriate intervention is. And one of the fundamental characteristics of deep learning, artificial intelligence, is the ability to keep sub-segmenting the population. If you start out with all people with depression, and then you narrow it down to people with severe, and then within that it's women versus men, it's elderly versus still working versus very young, and you go down and down and down through multiple different descriptors of a population. And as you get smaller and smaller and smaller, and you get to Korean second generation, employed, misses work half the year, et cetera. You can go down very, very narrow to see where the right kinds of interventions can be assigned. Referrals. In order, in the triage, to direct referrals, in the primary care, to direct the referrals, to avoid inpatient visits if possible. Again, in the clinical medicine side, e-consult can avoid roughly 50% of all specialty visits. It obviously varies by specialty. Some are easier to avoid than others. Endocrine, for example, never needs to see the patient. All they want are the lab values. Interestingly, behavioral health up until now has been the most difficult, not because it isn't easy to do an e-consult, but the specialist consults aren't available. There aren't enough providers out there to do the consultation side for a lot of the clinical systems that have been mounted. And finally, for management of chronic care, as I said, it can provide management for 80 to 90% of patients. It can address the home and community risks and modify behavior, and I'm going to show you examples of each of these. So don't take my word for it. I'm just describing the categories of impact. So let's look at triage, virtual triage first. We're starting here with symptom checkers. If you think about when you wake up and your kid has a problem in the morning, you've got a problem, and you go on, you might go to WebMD, you might go to the Mayo Clinic site, and you're trying to look up, what is it I have? What's wrong with me? Usually what you have to do is you type in headache, ? Diabetes. And then you have to read a whole lot, and then you say, well, that doesn't sound like me, and you back out and you try another guess. And so it's a very hit or miss kind of thing. What these AI systems do is use a chatbot to iteratively, in conversation with you, go deep enough to make a pretty accurate diagnosis in most cases. So Buoy is the fastest growing in the US. They last year had 40 million users, 23 million unique users in 1 year, in their first year of operation. So other entrants, Babylon from the UK, Giant from the Netherlands, Medictor from Spain. The interesting thing about the entrants from Europe is that they all have multiple languages, whereas most of ours are still just in English, which is kind of crazy, especially if you're from California. So have any of you gone on and tried any of these chatbot symptom checkers? You can, they're free. So go take a look. And remember the basic rule about innovation from Clayton Christensen, who's sort of the father of innovation in healthcare, is that innovations that are really disruptive are things you never see coming if you're part of the regular dominant system in that sector of society. You don't see it coming, it comes in from the side, and it's adopted by consumers because it's cheaper, it's more convenient, and compared to what we as the dominant systems think about, it's just good enough. It's not perfect. It doesn't answer everything, but for the consumer, it's good enough. Think about your own lives. How many of you use a Roomba or some other kind of a vacuum cleaner at home that's a robot vacuum cleaner? Yeah, fair number of hands, especially considering there's a lot of men out there who don't usually have responsibility for doing that. But I used to give Roomba as an example of this because today a much higher proportion of households have Roomba than was even evidenced here by the hands. And when Roomba first came in, it was, at that point, not even necessarily cheaper than a Hoover vacuum cleaner. But it was very easy to use because women were in the workforce. They could leave it going and go off and do their job. And so it's that way to think about innovation. Remember, it doesn't have to be absolutely perfect. It's pretty impressive that these systems are competitive. They're diagnosing 90 to 95% as well as the Harvard primary care physicians do in making their diagnosis. So go try them, but remember, you know, these are rough compared to sitting there with the patient in your office doing the interview. So they did clinical validation in urgent care and compared it to physicians who were, seeing the patients seeing the physician, and then before they did that, going through this on a kiosk. They did it for a whole bunch of presenting conditions, for chest pain, for headache, on and on and on. And their diagnostic accuracy was about 90%, and triage 95% compared to the Harvard physicians. And the thing about artificial intelligence is the physician's intelligence is not improving every 6 months or every week. They know what they know. I mean, they read a journal article maybe a couple times a week, and they see a lot of patients. But the AI system is seeing 3 million patients a month. They're getting smarter every week, every 6 months. And that's why AI will start out 20% as good as a physician and a year later be 95% as good as a physician. So when you look at these statistics, don't sort of rest on your laurels and think, it's only 95% as good as the physicians. A year from now, they're going to outcompete the physicians. So now, one of the things I mentioned is that people don't see this stuff coming. This is an example, this map, that we asked Bowie, the one that I was talking to you about that came out of Harvard, to map for us against some of our members. We listed some of our members. I don't see if Bay State is on there. Baycare is there, yeah. And we asked Bowie how many users there had been in their market areas in the last year. Well, here Baycare finds out that it's 1.8 million people, probably counting northern Florida or something like that. I admit this is probably a pretty loose market definition. But just the idea that so many of the people who potentially are your patients are exposed to or using this is something that provider systems should be aware of. And behavioral health patients are going on and using this too. They don't differentiate. And so you see down here in the lower right that CVS last year did a deal with Bowie. So when people come on to sign up for Minute Clinic, to make an appointment or see what the hours are on their phone, they can immediately log in to Bowie and go through the whole triage before they go to Minute Clinic. Now, you could ask, why would CVS do that? Because about 30% of the patients who come to Bowie don't need to go to any provider. They learn that they just need watchful waiting, stay home and take an aspirin. So that's depriving CVS of getting the volume, of getting those patients, the foot traffic in. And that's why it's really important. CVS is very smart. They realize that their future is not just retail. It's not just getting foot traffic into their stores. Their future is having patients wake up in the morning, have a problem, and think CVS can help me figure out what to do. They want to, quote, own the consumer in the healthcare area. They want the families to think, we should go look on the CVS site because they're going to be able to help us figure out, do we need to go to the doctor? Can we go to work? What's going on? So here's another company, and this is one that after I started talking about it, they asked me and I actually went on their advisory group, but it's completely text-based virtual primary care. So basically, your employer, it's mostly bought by employers today, your employer says to you, if you need a primary care doc and you don't have one now, or you can't get an appointment, you can just go on and use this. The cost to the employer per employee per month is $1. For all the primary care that employee can use 24/7. So it is very inexpensive, it's very convenient, and it's quite high quality. All of the physicians, this actually has physicians involved in each diagnosis and treatment plan, and they are all board certified, very well qualified. A lot of them are Hopkins, Mayo, Harvard, et cetera. Their physicians are licensed in all 50 states. You know what that means in terms of just the ease of operation. And 98.6 is approved to operate in all 50 states. They got 100,000 members by the end of the first 9 months, and 95% of the conditions or questions submitted to them that were appropriate for primary care could be resolved online. Now, they could send the patients for labs, like to LabCorp or Quest, and get the results back. But other than that, if it could be resolved in primary care setting, even if they went physically to primary care, they could do it. Over 25% of the visits are returning users with a new question, so people came back. They were satisfied. They thought this works for them. The average patient wait time is less than 30 seconds, so convenient. And over 30% of the visits are requested not just from the home, but coffee shop, airport, during a commute, from work. The Net Promoter Score for that first 100,000 patients was higher than Apple and Netflix, Kaiser Permanente, the health plans, and current primary care. And, I'm sorry, the numbers at the bottom on the early use by demographics didn't come through, but if you look, the orange or yellow bar on the right are people 44 years of age or older. So this wasn't just young techie people using it. So again, we have a shortage of primary care providers, so this is a way to meet that shortage of providers. But in the markets where there are already a significant presence, most of the provider systems are not really aware of them yet. This is not, this is why part of what we serve is an early warning device of how these trends are emerging. And here's an analogy to 98.6. This is the other company that I'm involved with. I'm on their board, which is Ginger, which some of you may have known 6 or 7 years ago because they were a very different company. They were just doing a text-based diagnosis of worsening of depression in some conditions. But they've changed now, and they're now an on-demand text-based system for coaching, CBT, and teletherapy and telepsychiatry. So it's basically full stack for behavioral health. They also, like a lot of the innovations, are selling to employers directly just because that's a good stepping stone eventually to selling to plans which have larger numbers. But there's a long record, as you all know, of cognitive behavioral therapy and coaching being very important in mild and moderate disease. And so this is making that available. And the difference for this and for 98.6, the reason that I included them is that their model includes real live people texting, not just a chatbot. So for some patients and some providers, it's a very key thing that there is a live clinical provider involved in reviewing the diagnosis, in communicating with the patient, and then in managing the diagnosis and the disposition. This is a very interesting way, and this comes out of the clinical side initially. It's migrated into behavioral health. This is behavioral economics for medication adherence. And it began with working with diabetics, and it was working with Medicaid dual population, so Medicaid and Medicare dual, so elderly, poor patients with diabetes and multiple comorbidities, and I pretty much guarantee you a significant number of them have depression as well. And their average adherence to their medication for diabetes was about 30%, pretty typical. And in 90 days with this system, they got to 86% adherence with very good persistence maintenance after that stopped. The way they do it, behavioral economics, is give them an incentive. Tell them you'll put $2 in a bank account for them every day that they take their smartphone, put the medications that they're about to take in the palm of their hand, and take a picture of it before they take the meds. And the picture can be diagnosed to make sure that it's the right meds and the right dosage. So you're tracking that as well. And the behavioral economics is not just the financial incentive, but knowing where is the tipping point. Because if you just ask them, did you take your medication? People say yes, but they don't. Not because they're trying to lie, but because they mean, yes, I'm going to go do it right now, and then they get distracted and they don't do it. But if you get them to put it in the palm of their hands, they're more likely to actually take it. So the adherence rate goes up, and the reason you know it's working is because the emergency room visit rate and the rate for hospitalization plummets. So quite logically, that's now being extended into many other chronic diseases and into behavioral health. Another example in behavioral health is EMOCA, which some of you may know, but that came out of directly observed therapy for tuberculosis. You remember they used to have to send the public health nurses out to the home to see each patient in the morning or afternoon, take their medicine. Well, that's not very feasible, especially with a widely spread population. So for some time, EMOCA and some other companies had developed an online directly observed therapy, somewhat like this that I was describing to you. And now they're using it for BUP. So they're actually making the transition into behavioral health just like wealth is. So that's part of the reason that I'm presenting some of these to you, that because everybody in the broader clinical world recognizes that behavioral health conditions are the most important comorbidity for most of our patients and need addressing that way. And as a primary diagnosis, this is also something that they can actually, with the right tools, begin to start addressing. Similarly, Chess, which is a relatively young company, was developed with the group at Yale, and they've done extensive research showing that their form of computerized cognitive behavioral therapy will advance the ability of substance abuse, starting with opioid users, recovery and maintenance. Very, very striking results from the research that they've done. So again, being able to extend to a population that your current provider capacity might only cover X number of population, 100,000, 10,000, 1,000 a year, depending on the size of your organization. Using these tools, some proportion of that population can use the digital tools, leaving your resources to be focused on those that are either not appropriate for or won't use them. And you can broaden at much lower expense. You don't have the physical need to build clinics as much, and you don't have to hire as much non-existing new providers. So that's the rationale of why people are moving in this direction. From the patient or consumer point of view, it's because they get access from their home, from their work. They don't have to take a half a day or a day off work if they're employed. And they have a much less expensive and much more user-friendly way to deal with their problems. Now, the provision of these kinds of digital solutions is, as we said, expanding very, very widely. And so Avia's role in Medicaid transformation is to focus on the patients in Medicaid or lower income, underserved, minority, multiple cultures and languages, how can we meet their needs? There is a huge amount of investment flowing into this area. You can see how the dollars have increased just in 4 years, between 2014 and 2018, they quadrupled. The focus up till now in the behavioral health market has been on commercial populations because that's where there is reimbursement available. And health providers on the medical side have been not fast movers in this space until recently. Companies are mostly, meaning the developers of technology, are going B2B through employers and then payers. Some are growing in B2C, like my strength had a big B2C strength. The largest number of companies today are focused either on building virtual networks of psychiatrists and therapists, which is an important function, but limited in its ability to meet the sheer numbers of the population that needs care, or in digitizing or gamifying self-management tools in cognitive therapy. The majority of the companies are focused on low and moderate acuity diagnoses, with the exception of some of the SUD companies like Emoca or Chess. So those are the patterns that we're seeing to date. And you can see in this period of disruptive transformation that triage, integration, self-care, medication adherence, intensive outpatient care, and SMI, network management, and many disease-specific apps, there is a tremendous shift into digital. And this is just giving you some examples in each of those areas. And by the way, I'm happy to have this deck distributed if any of the members want it, so you don't have to worry. I should have said that at the beginning, so you have to worry about notes if you were thinking about it. And what we do at Avia is filter this, looking at the product offering, features and functionality, workflow integration, technical infrastructure, the value of the data and the reports. The company approach, are they addressing disparities, whether the provider system or the community is addressed, partnership philosophy, the commercial terms. Is the company stable? If these are young companies, you need some evaluation. Are they going to be around 2 years from now or 4 years from now? How attractive is the pricing, the ongoing costs of operation, and do you have an opportunity to invest in them? Because if you're seeing something that 20 provider systems are adopting, that's a pretty good sign that this may do well. And demonstrated ROI. So those are some of the factors that we're evaluating. So I really appreciate this opportunity to describe this to you. I find it very exciting because when I talk with patients who are as sick as many of the patients you take care of and we see in our clinical side of things, being able to help with that is a real reward. So I'm glad to take questions if there's time. Otherwise, we can wrap up.
Thank you, Molly. Let's take some questions. I thought I knew everything that was going on, but boy, I was texting my innovation director. We got a lot to do. So, and I thought we were ahead, but not so much. So questions, and please use the microphones here in the audience. Questions? Well, let me ask you a question. How many are using some of these solutions now by hands?
There's one hand back there.
Okay. Go ahead. Hello.
Hello? Oh, okay, good. Thank you. I was wondering how you evaluate the evidence base for some of these interventions, particularly when they are delivering therapies and measure outcomes, and then how do you advise the members around what
Right.
can one expect from an outcomes perspective and
Right.
the solidity of that evidence base?
Yeah. In general, in digital offerings like this, the companies don't take the time or spend the money for a randomized control trial. So we just face that to start with. Usually what you get as evidence is the company makes a claim, which is highly suspect, of course, and then you go and talk with the users. And if the users have collected data about the impact, so for example, with the medication adherence with the smartphone, so that starts as just us basically saying, well, we want to talk with Mount Sinai Health System, with the other systems that have piloted this technology, and see what they saw. How difficult was it to use? What was the patient level of satisfaction? And most importantly, what were the results both clinically and in terms of utilization, like ED and hospitalization? If those are consistently good and bear some relationship to what the company claims, then that's probably what you're going to have until someone sponsors an academic piece of research. In the case of Wealth, the one that I just showed you, they had been working with the UPenn Center on Behavioral Economics and Healthcare, led by Kevin Volpe, who is a recognized expert in the area. It was based on existing academic research on healthcare application of this, and they are about to publish several articles. So they really lucked out or were smart in the way they approached that. But I've just described what you have to work with in most of these cases. And frankly, it's a choice. You could say, well, we just won't talk about it, or we're going to wait until we've got the randomized controlled trial, or at least a very controlled trial of some type. Unfortunately, these things are barreling ahead, so it's probably worth trying to find out. But we never take the company's word for it.
Thank you.
Can I ask which one of these that you're in the back there that you mentioned, that you raised your hand, which one of these you're using? Great, I'll be very interested. You know, I have to confess a personal fascination because I was a part of the team that did the first ever patient self-management online for diabetes in Silicon Valley in the late 90s. And I led the team that went to Wisconsin to try to buy the chess technology back then because it was so good. It was really inspiring. So I was delighted when I saw that it had evolved into behavioral health, because it seems I'd be very interested to hear how that goes and what your experience is. I know Geisinger is using them, and another of health systems are using them. Any other questions at all? Okay, well, I'm glad to talk with any of you during the break, and thank you very much. Thank you, Gail.
I think that the conversations I've been having in the middle of all of this is the elephant in the room, which is the workforce that we don't have. And without the digital solutions, we're not going to grow this workforce anytime soon. So these are the kinds of things that we have to do. And what I will say is that if you have the opportunity to invest in an innovation director, I would recommend you do that. It has really helped us to move our focus around patient care forward.